Welcome to the Epidemiology and Prevention of Vaccine Preventable Diseases webinar series, also known as the Pink Book series, presented to you today by the Immunization Services Division at the National Center for Immunization and Respiratory Diseases, Centers for Disease Control and Prevention in Atlanta, Georgia. I'm Dr. Raymond Strickus, a medical officer in our division, and I'm the moderator for today's session. For today's program, you need simply an internet connection for both the audio and visual portions of our program. The learning objectives for today's program are to describe the different forms of immunity, describe the different types of vaccines for the relevant disease or diseases. For each vaccine preventable disease, identify those for whom routine immunization is recommended. For each vaccine preventable disease, describe characteristics of the vaccine used to prevent the disease. Describe an emerging immunization issue. Locate resources relevant to current immunization practice, and implement disease detection and prevention healthcare services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, or in this case, immunization services to prevent health problems and maintain health. Today's agenda and program are the Epidemiology Prevention of Vaccine Preventable Diseases webinar series Pink Book section on meningococcal disease and vaccines, presented by a medical officer, Dr. Candace Robinson, who's part of the Communication and Education branch in our Immunization Services Division at the National Center for Immunization and Respiratory Diseases. For continuing education credit, please go to http://www.2a.cdc.gov/TCE online. For this live program, continuing education credit will expire September 6th, 2016. For the Enduring Archive course, CE credit will expire June 1st of 2018. When obtaining continuing education, you will be required to provide a verification code. Please watch and listen for the verification code during today's course. Verification codes will not be given outside of this presentation. CDC, our planners, and our presenters wish to disclose they have no financial interests or other relationships with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Presentations will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception of Dr. Robinson's discussion of meningococcal vaccine in a manner recommended by the Advisory Committee on Immunization Practices, but not approved by the Food and Drug Administration. CDC does not accept any commercial support. A list of resources for today's meningococcal disease and vaccines program will be available at https://www.cdc.gov/vaccines/ed/pinkbook/pb9.asp. If you have a question, please enter your question and type it into our QA pod you will see on your screen as the presentation unfolds. Let me turn the presentation now over to Dr.
Thank you, Dr. Strickus. Welcome to this discussion of meningococcal disease and vaccines to prevent it. Meningococcal disease is an acute, potentially serious illness caused by the bacterium Neisseria meningitidis. Neisseria meningitidis, or meningococcus, is an anaerobic gram-negative bacteria. Meningococci are classified by serologic methods based on the structure of the polysaccharide capsule. 13 antigenically and chemically distinct polysaccharide capsules have been described. Almost all invasive disease is caused by serogroups A, B, C, Y, and W. The relative importance of serogroups depends on the geographic location and other factors such as age. Neisseria meningitidis is a leading cause of bacterial meningitis and sepsis in the United States. It can also cause focal disease such as pneumonia and arthritis. Meningitis is also a cause of epidemics of meningitis and bacteremia in sub-Saharan Africa. Meningococci or cocci are transmitted by droplet aerosol or secretions from the nasal pharynx of colonized persons. The bacteria attach to and multiply on the mucosal cells of the nasopharynx. In a small proportion of colonized persons, less than 1%, the organism penetrates the mucosal cells and enters the bloodstream. The bacteria spreads by way of the blood to many organs. In about 50% of bacteremic persons, the organism crosses the blood-brain barrier into the cerebrospinal fluid and causes purulent meningitis. An antecedent upper respiratory infection may be a contributing factor. The incubation period of meningococcal disease is 3 to 4 days, with a range of 2 to 10 days. Symptoms include abrupt onset of fever, meningeal symptoms, hypotension, and rash. The case fatality rate is 10 to 15%, up to 40% in meningococcemia. Meningitis is the most common presentation of invasive meningococcal infection and results from hematogenous dissemination of the organism. Meningeal infection is similar to other forms of acute purulent meningitis with sudden onset of fever, headache, and stiff neck, often accompanied by other symptoms such as nausea, vomiting, photophobia or eye sensitivity to light, and altered mental status. Meningococci can be isolated from the blood in up to 70% of persons with meningitis. Meningococcal sepsis, bloodstream infection, or meningococcemia occurs without meningitis in 5 to 20% of invasive meningococcal infections. This condition is characterized by abrupt onset of fever and petechial or purpuric rash, often associated with hypotension, shock, acute adrenal hemorrhage, and multi-organ failure. Less common presentations of meningococcal disease include pneumonia, arthritis, otitis media, and epiglottitis. This is the hand of a child with meningococcal sepsis. This child has disseminated intravascular coagulation or clotting and is at risk of losing this limb. This is an adult with meningococcal sepsis who will lose the right arm because the tissue is not being oxygenated secondary to the blood clotting. Risk factors for the development of meningococcal disease include deficiencies in the terminal common complement pathway, functional or anatomic asplenia, and underlying chronic disease. Certain genetic factors may also be a risk factor. Household crowding and both active and passive smoking are associated with increased risk. Persons with antecedent viral infections are also at increased risk. Microbiologists working with Neisseria meningitidis isolates are at increased risk of infection and should be vaccinated. Cases of meningococcal disease, including at least 2 fatal cases, have been reported among microbiologists. These persons have worked with the N. meningitidis isolates rather than patient specimens. Studies conducted in the 1990s that focused on quantifying the risk for meningococcal disease among college students demonstrated the overall incidence among college students was similar to or somewhat lower than that observed among persons of approximately the same age in the general population. However, in a case control study involving 50 cases among college students, multivariate analysis indicated that first-year college students living in residence hall were at higher risk for meningococcal disease than other students. Other studies in the 1990s yielded similar results. During 2005 through 2013, an estimated 550 to 1,200 cases of meningococcal disease occurred annually in the United States. Incidence has declined annually since a peak of disease in the late 1990s. Since 2005, declines have occurred among all age groups and in all vaccine-contained serogroups. In addition, incidence of disease attributable to serogroup B A serogroup not included in the quadrivalent vaccine declined for reasons that are not known. There are three peaks in meningococcal disease incidence before 1 year of age, in adolescents and young adults, and in persons age 80 and older. The incidence of serogroups C and Y, which represent the majority of cases of meningococcal disease preventable by the conjugate vaccines, are at historic lows. However, a peak in disease incidence among adolescents and young adults 16 to 21 years of age has persisted, even after routine vaccination of adolescents was recommended in 2005. Comparing 2000 through 2004 to 2005 through 2009, the estimated annual number of cases of serogroup C and Y meningococcal disease decreased 74% among persons aged 11 through 14 years, but only 27% among persons aged 15 through 18 years. Serogroups B, C, and Y are the major causes of meningococcal disease in the United States, each being responsible for approximately 1/3 of cases. The proportion of cases caused by each serogroup varies by age group. Approximately 60% of disease among children aged 0 through 59 months is caused by serogroup B. Serogroups C, W, or Y cause 73% of all cases of meningococcal disease among persons 11 years of age or older. In the United States, meningococcal outbreaks account for 2 to 3% of reported cases. 98% of cases are sporadic. However, outbreaks of meningococcal disease continue to occur. Since 2010, serogroup C and serogroup B outbreaks have been reported to CDC. The onset of an outbreak is unpredictable, and the outcomes can be emotionally devastating to the affected communities and organizations. In certain outbreaks, vaccination against meningococcal disease is recommended to help stop the disease from spreading. Now we'll discuss the meningococcal vaccines. The first meningococcal polysaccharide vaccine was licensed in the United States in 1974. The current quadrivalent ACWY polysaccharide vaccine, Minimmune, manufactured by Sanofi Pasteur, was licensed in 1981. Each dose contains 50 micrograms of each of the 4 purified bacterial capsular polysaccharides. The vaccine contains lactose as a stabilizer. Meningococcal polysaccharide vaccine is administered by subcutaneous injection. The vaccine is available in single-dose and 10-dose vials. Diluent for the single-dose vial is sterile water without preservative. Diluent for the 10-dose vial is sterile water with thimerosal added as a preservative. After reconstitution, the vaccine is a clear, colorless liquid. The characteristics of meningococcal polysaccharide vaccine are similar to other polysaccharide vaccines, such as pneumococcal polysaccharide. The vaccine is generally not effective in children younger than 18 months of age. The response to the vaccine is typical of a T-cell independent antigen with an age-dependent response and poor immunogenicity in children younger than 2 years of age. In addition, little boost in antibody titer occurs with repeated doses. Vaccine response is improved by conjugation to a protein antigen. Routine vaccination of civilians with meningococcal polysaccharide vaccine is not recommended. Use of meningococcal polysaccharide vaccine should be limited to persons who are 56 years of age or older, expected to need meningococcal vaccine only once, or when neither MenACWY is available. Meningococcal conjugate vaccines are composed of meningococcal polysaccharide conjugated to a protein carrier. They elicit both T and B cell immunity. 3 meningococcal conjugate vaccines are licensed in the United States. 2 single component vaccines, Menactra and Menveo, and 1 combination vaccine with Hib, Menhibrix. Menactra, manufactured by Sanofi Pasteur, was licensed in 2005. Each dose of vaccine is formulated to contain each of meningococcal A, C, W, and Y polysaccharides conjugated to a diphtheria toxoid protein carrier. Menactra is approved for use in persons 9 months through 55 years of age. It is administered by intramuscular injection. Menactra is supplied as a liquid in a single dose vial and does not contain a preservative or an adjuvant. Menveo, manufactured by Novartis, was licensed in the United States in 2010. Menveo consists of lyophilized meningococcal serogroup A capsular polysaccharide conjugated to CRM197. That must be reconstituted with capsular polysaccharides of serogroups C, W, and Y conjugated to CRM197 in phosphate buffered saline before injection. Menveo is approved for use in persons 2 months through 55 years of age. It is administered by intramuscular injection. It does not contain a preservative or adjuvant. Menhibrix was licensed in the United States in 2012. Menhibrix contains Neisseria meningitidis serogroups C capsular polysaccharide, serogroup Y capsular polysaccharide, and Haemophilus influenza serogroup B capsular polysaccharide, each conjugated to tetanus toxoid. The vaccine is lyophilized and should be reconstituted with a 0.9 saline diluent. Menhibrix is approved as a 4-dose series for children at 2, 4, 6, and 12 through 18 months. The first dose may be given at 6 weeks. Limited data suggests that different conjugate vaccine products can be used interchangeably. Data are available regarding vaccination of Menveo after prior vaccination of either Menveo or Menactra. Whenever feasible, the same brand of vaccine should be used for all doses of the vaccination series. However, if vaccination providers do not know or have available the type of vaccine product previously administered, any product should be used to continue or complete the series. First, we'll discuss the routine adolescent MenACWY vaccine recommendations. Meningococcal conjugate ACWY vaccines are listed on the 2016 Child and Adolescent Immunization Schedule as outlined in red for high-risk children beginning at 2 months of age and for routine vaccination at 11 to 12 years of age, with a booster dose at 16 to 18 years of age. Again, ACIP recommends routine vaccination of either MenACWY vaccine at 11 or 12 years of age with a booster dose at 16 years of age. For adolescents who receive the first dose at 13 through 15 years of age, a one-time booster dose should be administered, preferably at 16 through 18 years. Although doses of MenACWY separated by 8 weeks can be counted as valid, it is preferable to use a longer interval between doses, 3 to 5 years if possible. In its 2005 recommendations for MenACWY, ACIP made no recommendation about revaccination pending the availability of additional data. Serologic data are now available from the manufacturer that show significant decline in antibody 3 to 5 years after vaccination, although few breakthrough cases have been reported. This graph from the CDC Active Bacterial Core Surveillance System shows the rates of meningococcal serogroups C and Y by single year of age through age 25 years during 1999 through 2008. Note the increase in rates for both serogroups at ages 17 through 21 years of age. Antibody persistence studies performed since the initial meningococcal conjugate vaccine recommendations in 2005 indicate that circulating antibody declines 3 to 5 years after a single dose of Menactra or Menveo. In addition, results from a vaccine effectiveness study demonstrate waning effectiveness, and many adolescents are not protected 5 years after vaccination. ACIP concluded that a single dose of meningococcal conjugate vaccine administered at age 11 or 12 years is unlikely to protect most adolescents through the period of increased risk at 16 through 21 years. On the basis of this information, in 2010, ACIP recommended adding a booster dose at age 16 years. Here are some other caveats about the adolescent booster dose recommendations. Healthy persons who receive their first routine dose of meningococcal conjugate vaccine at or after 16 years of age do not need a booster unless they become at increased risk for meningococcal disease. Routine vaccination of healthy persons who are not at increased risk for exposure to meningitis is not recommended after age 21 years. A booster dose is not recommended for healthy persons 22 years of age or older, even if the first dose was administered at 11 through 15 years of age. Now, we'll discuss MenACWY vaccine recommendations for persons at increased risk for meningococcal disease. These are the recommendations for children with functional or anatomic asplenia, including those with sickle cell disease. For children younger than 19 months of age with anatomic or functional asplenia, administer an infant series of Menhibrix or Menveo at 2, 4, 6, and 12 through 15 months of age. For children 19 through 23 months of age with anatomic or functional asplenia, administer 2 primary doses of Menveo at least 12 weeks apart. The doses are considered valid if administered at least 8 weeks apart. For children 24 months of age and older with anatomic or functional asplenia who have not received a complete primary series of Menhibrix or MenACWY, administer 2 primary doses of either MenACWY, Menactra, or Menveo at least 12 weeks apart. Doses are valid if administered 8 weeks apart. Do not administer Menactra to a child with asplenia, including those with sickle cell disease, until after the second birthday and at least 4 weeks after completion of all PCV13 doses. These are the recommendations for children with persistent complement components deficiency, including those taking Solaris. For children 2 through 18 months of age with persistent complement component deficiencies, administer either an infant series of Menhibrix or Menveo at 2, 4, 6, and 12 through 15 months of age, or a 2-dose primary series of Menactra starting at 9 months, with at least 12 weeks between doses. For children 19 through 23 months of age with persistent complement component deficiencies who have not received a complete series of Menhibrix or MenACWY, administer 2 primary doses of either MenACWY vaccine at least 12 weeks apart. Doses are valid if administered 8 weeks apart. For children 24 months of age and older with persistent complement component deficiencies who have not received a complete series of Menhibrix or MenACWY, administer 2 primary doses of either MenACWY vaccine at least 12 weeks apart. In June of this year, the ACIP voted to recommend routine MenACWY vaccination in all HIV-infected persons 2 months of age and older. The recommended primary series will vary depending on age. Those less than 2 years will be able to receive 4 doses of Menveo or Menhibrix or 2 doses of Menactra. Those 2 years and older will be able to receive 2 doses of Menactra or Menveo. Additionally, HIV-infected persons will be recommended to receive lifetime boosters. This will not be considered an official CDC recommendation until approved by the CDC director and published in the MMWR. Additional guidance regarding primary series and booster doses will be published in the MMWR. Publication is anticipated in the near future. For persons 2 through 55 years of age who are first-year college students aged less than or equal to 21 years living in residential housing, persons traveling to or residents of areas or in countries where meningococcal disease is hyperendemic or endemic, persons who are microbiologists routinely exposed to isolates of Neisseria meningitidis, and military recruits, administer 1 dose of MenACWY. Both MenACWY and meningococcal polysaccharide are recommended for use in control of meningococcal outbreaks caused by vaccine preventable serogroups A, C, W, and Y. Menhibrix may be used for age-appropriate persons in outbreaks specifically caused by the vaccine preventable serogroups C and Y. An outbreak is defined by the occurrence of at least 3 confirmed or probable primary cases of the same serogroup of meningococcal disease during a period of 3 months or less, with a resulting primary attack rate of 10 or more cases per 100,000 population. Children who received primary immunization before 7 years of age and remain at increased risk for meningococcal disease should receive a booster 3 years after primary immunization. Boosters should be repeated every 5 years thereafter. Persons who received primary immunization at 7 years of age or older and remain at increased risk for meningococcal disease should receive a booster 5 years after their previous dose. Boosters should be repeated every 5 years thereafter. ACIP also recommended in 2009 routine revaccination of certain persons at high risk of exposure. These groups include microbiologists with prolonged exposure to Neisseria meningitidis, and frequent travelers to or persons living in areas with high rates of meningococcal disease, such as sub-Saharan Africa or traveling to the Hajj in Saudi Arabia. These persons should be vaccinated every 5 years as long as they remain at increased risk. Meningococcal conjugate vaccine should be administered for persons 2 through 55 years of age. For persons now aged 56 years and older who were vaccinated previously with MenACWY and are recommended for revaccination, or for whom multiple doses are anticipated, for example, persons with asplenia and microbiologists, MenACWY is preferred. International travelers should receive a booster dose of MenACWI if the last dose was administered 5 or more years previously. Vaccination in the 3 years before the date of travel is required by the government of Saudi Arabia for all travelers to Mecca during the annual Hajj. For meningococcal polysaccharide vaccines, fever of 100 degrees to 103 degrees Fahrenheit within 7 days of vaccination is reported for up to 3% of recipients. Systemic reactions, such as headache and malaise, within 7 days of vaccination are reported for up to 60% of recipients. Fewer than 3% of recipients reported these systemic reactions as severe. The most frequently reported adverse events for Menactra in adolescents and adults include fever, headache, injection site erythema, injection site pain, and dizziness. Syncope was reported in 10% of reports involving Menactra. Of all reported events, 6.6% were coded as serious. Serious events included headache, fever, vomiting, and nausea. The higher estimates for local and systemic reactions on the slide come from pre-licensure studies cited in the vaccine package insert. The most frequently reported adverse events for Menveo in adolescents and adults were injection site erythema and injection site swelling. Syncope was reported in 8.8% of reports involving Menveo. Rates of local and systemic adverse events observed after administration of Menhibrix, not pictured on this slide, were comparable to rates observed after administration of Hib vaccine. Thus, Menhibrix was found to be safe and immunogenic for both Hib and meningococcal serogroups C and Y. We will now discuss the meningococcal B vaccines and recommendations. 2 recombinant serogroup B, MenB vaccines are licensed in the United States. MenB FHBP Trememba, manufactured by Pfizer, was licensed by the FDA in October of 2014. MenB 4C Buxero, manufactured by GlaxoSmithKline, was licensed by the FDA in January of 2015. Both are licensed for persons aged 10 through 25 years of age. Trememba is recommended to be used as a 3-dose series, administered at 0, 1 to 2, and 6 months. Trememba was recently FDA approved for use as a 2-dose series. The ACIP has not yet addressed use of Trememba as a 2-dose series. Buxero is recommended as a 2-dose series at 0 and 1 to 6 months. An important note regarding MenB vaccines. The 2 vaccine products are not interchangeable. The same vaccine product should be used for all doses. Based on available data and expert opinion, Trememba and Buxero may be administered concomitantly with other vaccines indicated for this age, but at different anatomic sites if feasible. The ACIP has not stated a preference for the use of one MenB vaccine over the other. There are 2 recommendations for meningococcal B vaccine use. A recommendation for use in individuals 10 years of age and older at increased risk of disease, and a recommendation for use in adolescents and young adults not at increased risk for disease. Buxero or Trememba should be administered to certain persons 10 years of age or older who are at increased risk of meningococcal disease. These include persons with persistent complement component deficiencies, including persons taking the drug Solaris, which impairs complement function, persons who have anatomic or functional asplenia, including sickle cell disease, microbiologists who are routinely exposed to isolates of Neisseria meningitidis, or anyone identified to be at increased risk because of a serogroup B meningococcal disease outbreak. Use in persons over the age of 25 years is an off-label ACIP recommendation. This is considered a Category A recommendation, meaning this recommendation applies to all persons with one of the listed high-risk conditions. Of note, certain other groups included in the meningococcal ACWY conjugate recommendations for persons at increased risk are not included in this recommendation. MenB vaccination is not recommended for children aged 2 months through 9 years of age. It's not recommended for persons who travel to or reside in countries where meningococcal disease is hyperendemic or endemic, because outbreaks in these regions are generally not caused by serogroup B. MenB vaccine is not recommended for routine use in first-year college students living in residence halls, military recruits, or all adolescents. A MenB vaccine series may be administered to adolescents and young adults aged 16 through 23 years to provide short-term protection against most strains of serogroup B meningococcal disease. The preferred age for MenB vaccination is 16 to 18 years. This is a Category B or permissive recommendation. The vaccine provider should discuss the benefit and risk of administering the vaccine with the patient and family to determine if the vaccine should be administered. It is estimated that approximately 15 to 29 cases and 2 to 5 deaths could be prevented annually with routine adolescent MenB vaccination program administered at 11, 16, or 18 years. A recommendation for college students only is estimated to prevent approximately 9 cases and 1 death annually. Both of these programs would come at a great cost. The current low prevalence of disease, coupled with the fact that important data for making policy recommendations for MenB vaccines are not yet available, resulted in the ACIP determining that insufficient evidence exists to make a routine public health recommendation that all adolescents be vaccinated with MenB vaccine. Given the seriousness of meningococcal disease and the availability of licensed vaccines, ACIP agreed that sufficient evidence exists to encourage individual clinical decision-making. Vaccination with meningococcal conjugate vaccines, meningococcal polysaccharide vaccine, Menhibrix, or MenB vaccines is contraindicated for persons known to have had a severe allergic anaphylactic reaction to a vaccine component, including diphtheria or tetanus toxoid where relevant. Recommended vaccines can be administered to persons with minor acute illness, such as diarrhea or a mild upper respiratory tract infection with or without low-grade fever. Vaccination should be deferred for persons with moderate or severe acute illness until the condition has improved. This slide shows a number of meningococcal resources. There are links provided to the ACIP meningococcal recommendations webpage, meningococcal infection page, meningococcal vaccination webpage. In addition, there are links for the Immunization Action Coalition's meningococcal webpage and the Children's Hospital of Philadelphia's Vaccine Education Center meningococcal webpage. And with that, I'll turn the session back over.
Thank you very much, Dr. Robinson. Let us proceed to your questions, but before we do that, I want to give you the continuing education information you need to access the continuing education program. The course code for today's presentation is WC264-080316. That's 080316, which is today's date. The verification code is 16-MENING, capital MENING. CE credit for today's program expires September 6th, 2016, and instructions are further available in the resource pod you should be seeing at your bottom left of your screen. I'll read the verification code one more time and we'll leave it up there while we're doing questions. The verification code is 16-MENING, MENING. The course code again is WC2645-080316, today's date. So let us move on to questions we've received. One question of interest to an individual is, if someone is infected with meningococcal disease once, should they still be vaccinated?
Yeah, so if someone is infected with meningococcal disease once, they should still be vaccinated. That person is likely only infected by one serogroup, and our meningococcal vaccines provide protection against multiple serogroups. So those patients should still be vaccinated, even if they have a history of disease.
Okay, thank you. Why are other types of crowded conditions, you mentioned the military recruits, college students and residence facilities, not included as risk factors, and the specific examples cited by the inquirer are jails and prisons?
So the ACIP considers recommendations for different groups and different groups of people. To date, the ACIP has not made the recommendation for this vaccine specifically for those incarcerated. However, if they are at increased risk for disease for another reason, they should certainly be vaccinated.
Okay, thank you. If you vaccinated a young child, an infant or a young child of a few years of age, how long after that would the first booster dose be given? The person said, would it be at 5 years of age or at some other interval after the final primary series?
So referring back to the slide on booster doses, this actually depends on how old the child was. So if the child received their primary immunization series before 7 years of age and they remain at high risk, let's say, for example, this is a child with sickle cell disease, then they should receive their first booster 3 years after primary immunization. The booster should be repeated every 5 years thereafter. Persons who received primary immunization at 7 years of age or older and remain at increased risk should receive their boosters 5 years after the primary immunization and then continue to receive boosters every 5 years thereafter if there is a continued risk.
Okay, there was a question about microbiologists, and there's a couple of them. The first one is, what do you mean by routine exposure? Does that mean that they're working with Neisseria meningitidis or maybe on a daily basis, a weekly basis, or some other interval? What makes them, at what point are they considered at increased risk and should be vaccinated?
So microbiologists, I think you could consider any one of those above cited options to be at increased risk. Daily, weekly, monthly. I mean, if there's they're routinely exposed at any interval to the isolates of this bacteria, you want to make sure that they're protected.
Okay, and then you said they need to receive both types of meningococcal vaccine, MenACWY and MenB. Would they then get a primary series of one, and can they be given a primary series of each of those, and can you give them concomitantly, that is, at the same time?
Yes, meningococcal conjugate vaccine and meningococcal B vaccines can be given concomitantly. So they can be given at the same visit or at any interval before or after one another. You just want to make sure you follow the rules for minimum intervals for each specific vaccine. So for instance, MenB, follow the intervals for that, and MenACWY, follow the intervals for that, but they can be given at the same time.
Okay. A question we've commonly received, and then we have another one from one of our listeners. A child received meningococcal vaccine at 11 or 12 years of age, but then got the second vaccination before 16 years of age. Does that child need another dose at 16 or older?
Yes, you should plan on giving this dose to the child. This is not um, recommended anywhere using language this prospectively. But since colleges will recommend a dose within the last 5 years for matriculating students, and since first years living in a dormitory have a requirement to have a dose of the vaccine after 16 years, we say that you should plan on still administering a booster dose after 16 years of age, even if they were given two doses at 11 or 12 years of age, 8 weeks apart.
Okay. Now, I guess the question is asked, is meningococcal B vaccine generally recommended for those on immunosuppressive therapy, such as after solid organ transplant or bone marrow transplant, or is it not recommended?
So currently, the ACIP recommends that vaccine for the four groups discussed and outlined in the presentation. So those are persons with persistent complement component deficiencies, including those on the medication Solaris, persons with anatomic or functional asplenia, including those with sickle cell disease, and microbiologists routinely exposed to isolates or persons identified at increased risk because of an outbreak. So those are the four groups for which the vaccine is routinely recommended.
Now, the question is, you discussed the provisional recommendation pending final approval at CDC and publication MMWR of meningococcal ACWY vaccines for persons with HIV infection. Would one want to be vaccinating high-risk people for HIV, though they're not yet infected, such as men who have sex with men ACWY, or does one need to have evidence of HIV infection?
So previously, for HIV infection, before this vote in June, HIV infection alone was not considered to place someone at increased risk. So in those cases, it was recommended for persons with HIV who had an additional risk factor. However, with this vote, it's recommended for all persons infected with HIV. I will say stay tuned and read the publication when it's published to get further details.
Okay, thank you. Um, question we've received in the past. A patient received a dose of meningococcal B vaccine, comes to our office, does not have a record of which brand of vaccine was given. How do we continue the series?
So in effect, if you don't know what was given before, you technically must start over. You can't continue the series. So you should pick whichever meningococcal B vaccine you want to use, and it probably is dependent upon what you have in stock in your clinic, and start with a new dose one. Um, so if you don't know whatever you have in your clinic, you just want to restart the series with whatever you have. However, that new dose one should be spaced at least 4 weeks after the unknown dose.
Thank you. Are there data that it's okay to give other adolescent vaccines with either meningococcal vaccine, whether it's men ACWI or men B? Is that okay to do?
Yes, you can provide either meningococcal vaccine, either men ACWI or men B, at the same time as the adolescent presents to clinic for their other adolescent vaccines, which are typically the Tdap and the HPV. All of these vaccinations can be given to the patient concomitantly.
Okay. Question we've received frequently is, because of the current vaccine shortage of the meningococcal polysaccharide vaccine for older persons, that is 56 and older, can we use meningococcal conjugate ACWY vaccines if they need it for travel in particular?
There is a men ACWY immunogenicity study in older adults, and older adults did not have as high of an antibody response to serogroup Y compared to older adults who received the polysaccharide vaccines. There is much more polysaccharide in the polysaccharide vaccine compared to the conjugate vaccine, which is thought to be the reason for the better response to the polysaccharide vaccine in older adults. However, if there is an urgent need for travel, then it is reasonable to administer men ACWY with the caveat that if additional doses are needed, then they should to um, adhere to administering MenACWY as a preference. So if the patient does need to travel, you can administer MenACWY during this time of meningococcal polysaccharide vaccine shortage.
Okay. You showed a graph that demonstrated three peaks of incidence for meningococcal disease in infants, in adolescents, and older persons. And we've talked about infants and older and adolescents to some extent, but there's been no discussion about older folks. And can you comment on why that vaccine, meningococcal vaccines, haven't been identified as something to give older persons?
So, for some older persons, they would be recommended to receive the vaccine, and those are persons at increased risk for meningococcal disease discussed in this presentation. There has not been the routine recommendation for use of the meningococcal vaccines in this age group as of yet. The ACIP has not made that recommendation. Generally, recommendations are made based on the available data regarding efficacy, safety, and immunogenicity. However, this age group has not yet been recommended to receive routine vaccination.
Okay, thank you. A questioner asks, can you clarify when one needs to separate meningococcal ACWY vaccine from pneumococcal conjugate vaccines? What is the rationale? Is that relevant to all meningococcal conjugate vaccines?
So, in persons with asplenia, and this may be the slide that you're referring to, I talked about the recommendations for persons with anatomic or functional asplenia. Um, in those instances, you want to make sure that the meningococcal conjugate and pneumococcal conjugate vaccines are not administered at the same time. And that's because in this population, there is some concern regarding interference between the two vaccines with resulting potential decreases in immunity. So in those cases, and we're specifically referring to people with asplenia, you want to make sure that those vaccines are separated by at least 4 weeks. And so you will notice on the slide, when you go back to review the slide that discusses children with functional or anatomic asplenia, it's recommended that those children not receive Menactra until at least age 2 or at least 4 weeks after they have completed that primary pneumococcal conjugate vaccine series.
So to follow up, is the limitation of the 4-week separation relevant to Menactra only or to Menactra and Menveo?
It's relevant to Menactra only. Menveo is not a concern for interaction. So it's relevant to Menactra only.
Okay, thank you. Is there any contraindication of giving either meningococcal vaccine? I think the questioner is asking about MenACWY vaccines to people with immunosuppression, transplant recipients is the example given, but who also have one of the other conditions for which vaccination is recommended, say that's a microbiologist or someone who's lost the spleen.
Yeah, so MenACWY vaccines is an inactivated vaccine, so it can be administered to a person who may have some immunosuppression for some other reason, but are still at high risk due to another condition. So yes, it can be administered in those cases.
Okay. You talked about travelers, and I think you talked about MenACWY vaccine as an indication for travel to certain parts of the world. What is the reason that we don't recommend meningococcal B vaccine for travelers?
So, vaccine is not recommended for persons who travel to or reside in countries where meningococcal disease is hyperendemic or endemic. And this is because the risk of meningococcal disease in these countries are generally not caused by serogroup B disease. So that is why this vaccine is not recommended for travelers.
Okay, thank you. Um, Let's see. I'm looking to see if we've gotten any other questions that we haven't answered. There was a general question. Perhaps you can help the listener with this. They'd like to see where meningococcal vaccines fit in the overall childhood immunization schedule or the adult schedule. And they want to know how they can get view the most current schedule. Could you comment on that?
Yeah, so the most current adolescent or child and adolescent and adult immunization schedules are available on the CDC website, on the CDC vaccines website. You can go there, and on the vaccines homepage, you will find links to both the schedules for birth to 18 years and the schedules for those 19 years of age and older.
Okay, we've got one more question here before we wrap up. If a patient received only the liquid portion of Menveo, should they be revaccinated? And if so, when should they be revaccinated?
So for Menveo, I believe you're saying that it did not get reconstituted prior to administration to the patient.
Correct.
So in that case, there actually did not receive a portion of the vaccine. So as stated earlier, the lyophilized meningococcal subgroup A vaccine is contained within the powder, and then the C, W, and Y are within the liquid component. So that person would still be at risk of serogroup A disease. In that case, the person um, should be revaccinated with the appropriately reconstituted dose. Now, if you don't have, you want to make sure that you're using the manufacturer's diluent. So if you don't have the diluent available, you want to make sure you contact the vaccine manufacturer to get that diluent to make sure you can to make sure you use the correct one in that instance.
Okay, thank you very much. That's all the time we have for questions. Have the questions and answers that we've answered today, as well as the ones we did not have a chance to address, completed in writing and post them as part of our resources for today's program. So please be aware of that. We're sorry if we didn't get to your question. We got to as many as we could. So let me repeat the continuing education information and some additional information for your benefit. The CE credit website is http://www.2a.cdc.gov/TCE online. The live event course number is WC2645-080316, today's date. The CE credit for today's live program expires September 6, 2016. For the Enduring Archive course number, that's WD2645-080316, today's date. The CE credit for the Enduring course expires June 1, 2018. The verification code for either format of the course is the same, 16-MENIG, 16-meninge. For help with the online CE system, which usually works very well, but if you need help, you may call between 8 a.m. and 4 p.m. Eastern Time, 1-800-41-the letters TRAIN, TRAIN, or email the CE unit at ce@cdc.gov. If you have immunization questions you want answered that we didn't address, you need an urgent answer, or have other immunization questions that you wish to ask at any time, please email us at nipinfo@cdc.gov, nipinfo@cdc.gov. If it's about today's program, please indicate in the subject line is from today's webinar about meningococcal disease. If you have general immunization questions, you can also call us at 1-800-CDC-INFO between 8 a.m. and 8 p.m. Eastern Time, Monday through Friday. Additional resources for today's program, and we'll post these and other ones on our website with the program notes and slides and transcript and questions and answers. The Pink Book is available at http://www.cdc.gov vaccines/pubs/pinkbook/index. Our homepage, as Dr. Robinson said, is cdc.gov/vaccines/default.htm. Other resources are at cdc.gov vaccines/ed/downloads/imz-resources. and our Twitter handle is at CDCIZLearn. So that's the end of today's program. Let me thank Dr. Robinson very much for presenting the information and answering many of your questions. Thank you very much from Atlanta. Please join us next week for the next program in our series of the Pink Book webinar. Good day and be well.